All right. Thank you everyone for joining us this evening. And thank you, Dr. Amiri, for hosting this webinar. Today, What's Up Doc will be discussing transgender hormone therapy. For the sake of questions, just so you don't forget, feel free to enter them into the chat as they come up. And then at the very end, we can answer them unless Dr. Amiri would like to do otherwise. But from there, I will let Dr. Amiri take over. So thank you so much, and it's all yours.
Hi, everyone. I'm Hoda Amiri. I'm an endocrinologist and an assistant clinical professor at the University of California, Riverside. And today I'd like to talk to you about transgender hormone therapy. So we'll start with some definitions. When we say gender identity, we mean an individual's innate sense of feeling male, female, neither, or some combination of both. So this is the way someone feels inside. Whereas gender expression is how gender is presented to the outside world, like feminine, masculine. So gender expression is how it's presented outside. Gender incongruence is when someone's gender identity or their gender expression is different from what is typically associated with their designated gender at birth. And gender dysphoria is when this gender incongruence causes distress or discomfort. And when we say someone is transgender, it means some people whose gender identity or gender expression is different from what is typically associated with their sex designated at birth. When we say cisgender, it means someone is not transgender. When we say transgender female, we mean someone who has a feminine gender identity, but who was designated a male sex at birth. Whereas transgender males means someone with a masculine gender identity who is designated a female sex at birth. Sexual orientation is frequently confused with being transgender, but sexual orientation is something completely different. It's an individual's pattern of physical and emotional arousal, and the gender of person to whom someone is physically or sexually attracted to. So like gay, lesbian, straight, and this has nothing to do with being transgender. A transgender person can be gay, lesbian, straight. So prevalence is about 0.3 to 0.6% of the adult population. So it's estimated about 0.3 to 0.6% of the adult population is transgender. Mechanism is unclear. Some studies have suggested possible biological factors that affect someone to be transgender versus someone to be cisgender. A study found that there was no difference in the level of sex hormones between transgender and non-transgender people. So this does not affect someone being transgender or cisgender. Another study found that there was greater transgender concordance among identical twins versus non-identical twins. So this suggests some genetic factors that could affect it. And another study found that there's a neuroanatomical difference associated with gender identity. So some combination of some factors could possibly affect someone being transgender versus cisgender. So what kind of interventions can we do for our transgender patients? Hormone therapy, which we will discuss about today. There are multiple surgical options for our transgender patients, which I will briefly talk about. Facial hair removal and modification of speech and communication. These are very important for many of our transgender female patients. So when we have someone, a transgender patient who wants to start hormone therapy, what criteria do we use to start someone on hormones? So there's 4 different criteria. One is there has to be a persistent, well-documented gender dysphoria or gender incongruence present. So when we say persistent, we mean at least for 6 months. And this diagnosis can be made by a mental health professional, which can be a psychiatrist, therapist, or if the treating physician, either an endocrinologist or a primary care doctor, if they feel comfortable enough, they can make the diagnosis themselves. 2 is the capacity to make a fully informed decision and to consent for treatment. 3 is the age of majority in a given country. But this doesn't mean that younger patients cannot get hormone therapy. They can, but it's just they have to follow with a pediatric endocrinologist and they have to go through a different criteria. If there's any mental health concerns before starting hormone therapy, these need to be addressed and reasonably well controlled before we start hormones. So what criteria do we use to diagnose someone with gender dysphoria? We usually use something called DSM-5 criteria for gender dysphoria. And this has 2 main factors. One is there has to be a marked incongruence between someone's experienced or expressed gender and their natal gender, and this have to have lasted for at least 6 months in duration. And second factor is this condition is associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning. So when we see a patient for the first time for transgender hormone therapy, first we like to confirm diagnosis of gender dysphoria. And we like to talk to patients about their expectations, what their goals are with hormone therapy, what kind of physical changes they're hoping to have. We like to discuss fertility options before starting hormones because, as we'll talk more about it in our future slides, hormones can affect someone's fertility, and sometimes this could be permanent. So we need to talk about options before starting hormones. And obviously, we like to talk about risks and benefits of treatment. Goals of hormone therapy is to first, we like to reduce the level of endogenous sex hormones, meaning we like to reduce the levels of hormones that the person already has in their body. And we like to replace that with sex hormones that is consistent with the person's gender identity. So our end goal is to minimize the secondary sexual characteristics, which is different from someone's gender identity, and increase the secondary sexual characteristics that's in line with someone's gender identity. So we'll start with feminizing hormone therapy. So this is for someone who is trying to transition from male to female. So as we talked about, we like to suppress their endogenous hormones. So we like to suppress testosterone. In order to suppress testosterone or androgen is another word for male hormones. In order to suppress testosterone, we use a medication called spironolactone. This is the medication that we most commonly use. It is oral, it is cheap. It's actually a blood pressure medication, but at higher doses, it can suppress testosterone. The side effects are sometimes it can cause elevated potassium level, and sometimes it can cause kidney dysfunction. So we like to monitor potassium and kidney function in patients who are on spironolactone. And other options are GnRH agonists. These have fewer side effects. These are very effective, but the downside is that these are expensive and it's an injection. So we really rarely use this. Only if there's only if someone cannot tolerate spironolactone is when we would think about using GnRH agonists. Most patients tolerate spironolactone just fine. I rarely had any issues with spironolactone. So these are the doses of the medications we use. This is from UCSF transgender guidelines. So for spironolactone, we usually start with 50 milligrams twice a day. If there's any concerns about side effects or if the patient prefers, we can start with a lower dose. And then based on their testosterone level, we can, if they don't get enough testosterone suppression, we can go up on the dose up to 200 milligrams twice a day. Other options are finasteride and dutasteride that we'll talk about in my next slide. So 5-alpha reductase inhibitors like finasteride, these are another option we can use for testosterone, for suppression of androgens. Uh, these medications have less anti-androgen effect. These medications, we usually use it for prostate disease in cisgender men. And what they do is they inhibit testosterone to dihydrotestosterone conversion, which is dihydrotestosterone is a more potent form of testosterone. This may be a good choice for someone who is unable to tolerate spironolactone or who have contraindication to use of spironolactone. This can be a good option. Other options are bicalutamide. This is a direct anti-androgen. We rarely use this because of small but not fully quantified risk of liver function abnormalities. There has been reports of several cases of fulminant hepatitis, meaning severe liver dysfunction, which happens over a few days to few weeks. So because of this risk, we prefer to not use this medication. And then there's cyproterone acetate, which is a strong anti-androgen. But again, this one also has risk of fulminant hepatitis, and it's not available in the US, so we don't use this medication. So we talked about suppressing testosterone, and now we have to replace it with a hormone that's in line with the person's gender identity. So in this case, for transgender female person, we start on estrogen. There's different options for estrogen. There's 17-beta estradiol, which is oral and it's cheap. There's estradiol patch. This one has less risk of thromboembolism or blood clots. So I prefer this over the oral or the injection form. I usually start with the patch, and if there's any issues, I can always change it to the oral or the injection. The injection form is estradiol valerate or cypionate. The injection is every 2 weeks intramuscular. This can be done at home if a person is comfortable, or this patient can come to the clinic to have the injection done. These are the doses of the estradiol we typically use. For oral, we use 2 to 4 milligram initially, and then depending on a person's clinical changes and their estradiol level, we can go up to 8 milligram maximum. For transdermal estradiol, we start with 100 microgram, go up to 400 microgram. And these are the doses for our injection forms. What about progesterones? I frequently get questions about progesterone. So there's no well-designed study of the role of progesterone in feminizing hormone regimens. There are some anecdotal data about improved breast or areolar development. Some suggest that it improves mood or libido. If a patient requests, I have no problems prescribing it to see if it helps. I usually prescribe micronized progesterone, I start with 100 milligram daily. So once we start these hormones, what kind of physical changes do we see? So we see redistribution of body fat. So in transgender females, we see more fat in the hip area. This happens, starts within the first 3 to 6 months, and you'll see the maximum effect in the first 2 to 3 years. We have decrease in muscle mass and strength, softening of skin and decreased oiliness, decreased sexual desire, decreased spontaneous erections, male sexual dysfunction, which again means decrease in erections. These happen within the first 1 to 3 months, and these are because of lower level of testosterone. Breast growth starts in the first 3 to 6 months, but you'll see the maximum effect after 2 to 3 years. We'll talk about it more on future slides, but many patients are not happy with the level of breast growth, and they want to have a breast augmentation surgery. We usually ask the patients, we recommend to wait at least a year to see the full effect of the hormone therapy before deciding for surgery, but it's not an absolute requirement. They can have the surgery at any time. You'll see decreased testicular volume. This happens in the first 3 to 6 months. Decrease in sperm production, decrease in terminal hair growth. This takes a little longer, about 6 to 12 months, and especially facial hair is more resistant to hormone therapy. So many patients decide to get laser hair removal for their facial hair. The effect of hormone on scalp hair is variable, and the voice doesn't change with hormone therapy. So as we talked about, effect of androgens or testosterone on the skeleton, like greater height or size and shape of hands, feet, jaws, pelvis, and voice cannot be reversed with hormone therapy. In transgender males, the relatively lower height and broader hip in transgender males cannot change with testosterone treatment. In transgender female, after orchiectomy or surgical removal of testis, we can stop the anti-androgen treatment because when you don't have testis, testis is the organ that makes the testosterone. If you don't have testis, then you don't need anti-androgen treatment. And they still need to continue with estrogen treatment. Now for transgender men, so someone who's transitioning from female to male, we use testosterone for these patients. There are different options. There's testosterone cypionate or ethynate. These are injection form. These are very effective. We can do this intramuscularly or subcutaneous. I usually prefer subcutaneous because it's less painful and patients can do it easily at home. I mean, intramuscular can also be done at home, but subcutaneous is easier and less painful. Subcutaneous is not FDA approved yet, but it is just as effective and safe as intramuscular. The injection can be done weekly or every 2 weeks. I prefer weekly because you get more stable level of testosterone, whereas with every 2 weeks, the testosterone level can go up and down. And testosterone gel is another option. You need daily administration with testosterone gel. It is more expensive compared to the injection. Same with testosterone patch. It is daily administration and it is more expensive. And some patients don't absorb testosterone through skin as well. So in these patients, we'll have to switch them to the injection form. These are the doses of testosterone we use with testosterone cypionate. I typically start with 50 milligram once a week. And if we want to do every 2-week injection, then you double the dose. So 100 milligram every 2 weeks. And for gel, I typically start with 50 milligram daily. For patch, we start with 4 milligram daily. There is the option of testosterone undeconate. This is a more long-lasting testosterone injection, and you need an injection every 10 weeks. We rarely use this one because the injection has to be done at the clinic and it is associated with some side effects, so I rarely use this one. So these are the masculinizing effect we see with testosterone in transgender males. So increased skin oiliness and acne, this is because of testosterone. This happens in the first 1 to 6 months. Facial and body hair growth happens in the first 6 to 12 months. Scalp hair loss, again, because of testosterone, just like cisgender men who have male pattern baldness. This is because of testosterone, they start losing their hair. This happens in the first 6 to 12 months. You have increased muscle mass and strength in the first 6 to 12 months. Fat redistribution happens in the first 1 to 6 months. So less fat in the hip area and more fat in abdomen area. The periods will stop within the first 1 to 6 months. You may have clitoral enlargement within the first 1 to 6 months, vaginal atrophy in the first 1 to 6 months, and deepening of the voice happens 6 to 12 months, but I've seen changes sooner in many of my patients. So once we start hormone therapy, what do we do after that? We'll have to monitor every patient who is on hormone therapy. For the first year, we like to monitor them every 3 months. After year 1, if their hormone levels are stable, we can do the monitoring less frequently. We can do every 6 months or every year, once a year. In every visit, we like to do a clinical assessment, what kind of physical changes they've had, if they're happy with the physical changes, if they're having any side effects. And for transgender males, we like to maintain their testosterone level in the physiologic normal cisgender male range. So for patients who are taking testosterone injection, we like to check their testosterone level in between their two injections. And the target level for testosterone is about 400 to 700, which is around the range for cisgender men. For transgender females, we like to check their testosterone and estradiol level. Like we talked about, we like to suppress their testosterone. So we like to keep their testosterone level less than 50. And their estradiol level should not exceed the peak physiologic range, which is between 100 to 200. So in every visit, we check their labs, and depending on their lab results and clinical findings, we decide about increasing or decreasing their hormone doses. These are the labs we typically order. This is for male to female transgender hormone therapy. So as we talked about, for male to female, we use a medication called spironolactone to suppress their testosterone. So spironolactone can cause increase in potassium and abnormal kidney function. So we check BUN creatinine, this is for kidney function, and potassium level at every visit. And then lipids, these are cholesterol levels. A1C is for screening for diabetes. These we don't need to check for every patient, but depending on their risk factors, we can decide if we need to check their cholesterol and if we need to screen them for diabetes. We also need to check estradiol and testosterone levels at every visit, sex hormone binding globulin and albumin, and these are because sex hormones are bound to these proteins in the blood, and that's why we check those. Female to male transgender monitoring, again, for cholesterol and for diabetes screening, it's based on their risk factors. We like to check estradiol, testosterone, sex hormone binding globulin, albumin, and also hemoglobin and hematocrit. We check those because testosterone can increase the level of hemoglobin and hematocrit, and that can potentially increase the risk for stroke. So we need to monitor the hemoglobin and hematocrit levels. So what are some of the side effects of hormone therapy? So for transgender female patients who use estrogen, some of the side effects are thromboembolic disease, which means blood clots. And some of the other side effects, macroprolactinoma. This is a pituitary mass that produces a hormone called prolactin. Using estrogen can increase the size of this prolactinoma. And so before we start estrogen, we like to ask the patients about the symptoms, if they're having any symptoms of prolactinoma, and if so, we need to check their prolactin level and treat the condition before we start them on hormone therapy. And a slightly increased risk of breast cancer, coronary artery disease, cerebrovascular disease, cholelithiasis or gallbladder stones, and increased triglyceride levels. These are some of the side effects of estrogen. For testosterone, like we talked about, it can cause elevation in hematocrit, which means erythrocytosis is elevation in hematocrit, which again can increase the risk for stroke. And other side effects are severe liver dysfunction, coronary artery disease, cerebrovascular disease, hypertension, and breast or uterine cancer. Are there any contraindications to starting hormone therapy? For transgender females, obviously, if they have any estrogen-sensitive tumors, like a breast cancer that's estrogen-sensitive, that's a contraindication for starting hormone therapy. There are some conditions that you need to watch, and there's a precaution for this condition, like venous thromboembolism or blood clot. If someone has a history of blood clot or have severe liver dysfunction, then we need to have a discussion with the patient regarding the risk of estrogen and decide. And then transmasculine, so for testosterone treatment, testosterone sensitive tumors are contraindication for treatment. with testosterone, if they have pre-existing problematic polycythemia, which means if their hemoglobin or hematocrit levels are elevated in the first place before starting the hormones, then we need to address that condition before starting someone on testosterone. If they have severe chronic liver dysfunction, that's a contraindication for hormone therapy. What about for gender non-binary people? So these are patients who do not live within the binary gender narrative. So they do not identify as male or female. So for these patients, hormone therapy should be guided by the person's desired configuration of secondary sex characteristics. So we have to have a discussion with the patient what kind of physical changes they would like. And depending on our discussion, we can consider a low dose hormones, or we can do hormone therapy for a limited period of time. Also for these patients, surgical options can be considered. So what about cardiovascular health? So for transgender men who are taking testosterone versus non-transgender women, some studies have shown there's the cardiovascular risk is unchanged. So it says that the testosterone doesn't necessarily increase the risk of cardiovascular disease. There are some studies in transgender women versus non-transgender men. Some studies have suggested increased morbidity and mortality from MI or heart attack and stroke. But these studies did not adjust for some of the risk factors like tobacco use, obesity, and diabetes. So we can't say for sure, but transgender women, hormone therapy, it could possibly increase the risk of heart attack and stroke. So for every person, every transgender person we are treating with hormones, we need to evaluate for their cardiovascular risk factors. We may use cholesterol levels, we may screen for diabetes and use other diagnostic tools to evaluate for cardiovascular health. What about cancer screening? Do we need to do breast cancer screening, cervical pap smears, prostate cancer screening for transgender patients? So as a rule of thumb, if a person has a particular body part or an organ, the screening should be done regardless of their hormone use. So for transgender men, if they have their cervix, they need the pap smear. They need to follow recommendation for non-transgender women. For breast cancer screening for transgender men, if they have not had a mastectomy or if they only had breast reduction surgery, then they need to have a breast cancer screening according to guidelines for cisgender women. For transgender women, the data is limited, but general recommendation is to follow breast screening guidelines for cisgender women. For prostate cancer screening for transgender women, we need to individualize screening according to someone's personal risk factor for prostate disease and prostate cancer. And I'll talk briefly about some of the surgical interventions that are available for transgender patients. I'm not a surgeon, I don't do any of these surgeries, but I just wanted to talk about it just for us to get an idea. So male to female interventions, so facial feminization is one of the interventions that is available. For this, no psychiatric referral is needed. The facial feminization surgeries that can be done is forehead contouring, blepharoplasty, which is eye and lid modification, cheek augmentation, rhinoplasty or nose surgery, lip augmentation, mandibular angle reduction. You see here, this is mandible, and genioplasty or chin width reduction, and tracheal shave. So these are some of the surgeries that can be done. Breast augmentation is another surgical intervention that can be done for transgender females. So for breast augmentation, usually one referral letter from a qualified mental health professional is needed, in addition to all the same criteria we used for hormone therapy: persistent, well-documented gender dysphoria, capacity for informed decision-making and consent, age of majority, and well-controlled medical and mental health comorbidities. It is recommended for the patients to wait at least 12 months after hormone therapy before going for surgery. But again, this is not required. So patients can have this surgery at any time. Up to 80% of patients reach Tanner stage 3, as you can see in this picture. Breast after 12 months of hormone therapy. Many patients are not satisfied with this size of breasts, and they will go for breast augmentation surgery. It's been shown that higher estrogen level necessarily doesn't mean larger breasts. Most likely the breast size is multifactorial, and it depends more on genetics and the age at which we start hormone therapy. For patients who decide to undergo breast augmentation surgery, what they do is put in a prosthetic implant, which is made of a silicone shell with saline or cohesive silicone filler. And this is placed either underneath the breast tissue or under the pectoralis muscle, as you can see in this picture. Vaginoplasty or genital surgery for transgender females. For this one, we need 2 referral letters from qualified mental health professional, all the same criteria for hormone therapy, but in addition, a patient needs to have been on hormone therapy and has to have lived in the desired gender role congruent with the person's gender identity for at least 12 months before going for the surgery. So the procedure they do for vaginoplasty is penile inversion vaginoplasty. So they do orchiectomy, meaning they remove the testis. They do penile deconstruction. They make a sensate neoclitoris, as you see here, neourethral meatus. They make a vaginal cavity. They usually use the skin from the scrotum and party skin from penis to make this new vagina. And they also do labioplasty to create an aesthetic and feminine external appearance of the genitalia. They usually recommend for hair removal prior to surgery to avoid any infections. The results have been encouraging. Post-op, 75% of patients reported the ability to have vaginal intercourse. 70 to 84% reported the ability to have orgasm. 76 to 100% reported satisfaction with their vaginal length. And some of the other feminizing procedures that can be done is body contouring procedures like abdominoplasty or tummy tuck or gluteal augmentation or buttock lift and liposuction. And surgery to raise the voice pitch or voice feminization, laser hair removal, hair transplant. These are all other feminizing procedures. For female to male interventions, one procedure that can be done is masculinizing chest reconstruction or top surgery. Many of our transgender men are bothered by their breasts, and hormone therapy is not necessary to have this surgery done. Testosterone decreases glandular tissue and increased fibrous connective tissue, but it doesn't cause much of a change in breast size or appearance. So the criteria for having top surgery for transgender men is the same as the criteria we use for hormone therapy. So continuous use of testosterone is not required to have this chest surgery. For genital surgery for transgender men, just like transgender women, they need 2 referral letters, 12 continuous months of hormone therapy, and living in desired gender role. The procedures that can be done is hysterectomy or removal of uterus, oophorectomy or removal of ovaries, vaginectomy, and metoidioplasty. So this is a procedure where they use only local tissue, no grafts. They make a small, about 1 to 3 centimeter phallus, and this phallus may become erect, as you see in this picture. Another procedure is phalloplasty with complete reconstruction. With this procedure, you get a larger penis, but this cannot become erect, and you need an implant for erection. So how about fertility? Can transgender people have children? So as we talked about, before starting hormone therapy, we like to talk to our patients about fertility. It is possible for fertility to return once we stop hormone therapy for a period of time. And this period of time is not, we don't exactly know how much time. It's different in every person, but some patients may experience permanent loss of fertility. So because of that, before starting hormone therapy, it's better to talk to our patients about, for transgender women, we like to talk to them about sperm banking. For transgender men, we like to talk to them about freezing their eggs or freezing embryos. And all transgender people who have gonads and engage in sexual activity that could result in pregnancy, they need contraception. Just because someone is on transgender hormone therapy does not mean they can't get pregnant. And what are the outcomes of hormone therapy? So a study has shown that sex reassignment that includes hormonal interventions in individuals with gender dysphoria likely improve gender dysphoria. 80% of patients reported that their gender dysphoria improved. Psychological symptoms improved in 78% of patients. Quality of life improved in 80% of patients, and sexual function improved in 72% of patients. And that is all. And thank you, everyone. And I'm ready to take any questions. And these are my references. So Endocrine Society Guideline for Transgender Hormone Therapy, UCSF Transgender Guidelines, all of these are available